Let's get started. Trinavia, because I'm CDs right now, and some of you who were otherwise engaged this morning are just now joining us and are wondering what you missed. What I want you to know is that you've missed a great deal of fun and excitement, but we are ready to catch you up and pull you right into the madness. So I am Lindy Forthover. I'm a professor in the Department of Public Health Sciences. I have been given the privilege of attempting to facilitate this synthesis session this afternoon. And basically what that really means is that at the end of it, I'm the one you'll all be mad at because we will have run out of time to hear everything that you are wanting to say or questions you want to ask. Our AC folks have given us an incredibly big charge and a fast timeline in which to accomplish it. So let me just recap very, very quickly what we heard early this morning in our plenary session. We heard from Mecklenburg County Health Department Director Gibby Harris, who talked about her enthusiasm for the action that would come out of today's session. We heard from Dr. Joseph Telfair, a professor at Georgia Southern University, who shared with us his perspective on the importance of thinking about health and also health equity from the perspective of context and thinking about systems, thinking about root causes, understanding that poverty is an overarching cause of many, if not all, of the disparities that we worry about, and thinking about how important it is to establish trust if we are to address and eliminate those inequities. Then we heard from AJ Calhoun from Moving on Opportunity here in Charlotte, and he really provided some impressive data on how localized these issues are, that health and opportunity structures are local. You hear in real estate, location, location, location. Well, that's true when we're talking about health. And also what he shared with us is the need to think about proximity to opportunity structures and the idea that sometimes what matters most in terms of predicting someone's future status is not necessarily what they themselves are achieving at some point in time earlier in life, but rather, are they situated in a context or an environment in which they are proximal or close to resources? And he also talked about the importance of finding opportunity bargains and being able to capitalize on those. So we heard all of that, and our heads were stewing on all those great ideas and insights. And then we broke out into 5 breakout groups. And what we're going to do now is hear from the reporters from each of those groups. They're going to have a very brief 5 minutes in which to encapsulate a lot of work that they've done already today. And then I'm going to pull us back together and attempt to identify some common themes, some paths forward for us, and to just get us thinking about what are the next steps in terms of the synthesis. I'm going to ask that as you are listening to the breakouts, that you jot any clarifying questions you might have in the chat box. And as we go through this, any questions or comments or, hey, what about this? You're missing a really important perspective. Those are all things you can dump into the chat. And I will attempt to get us as much time as possible to address those during the time we have together today. So I'm going to ask our aisle partners to share the breakout slides, and I'm going to ask Trinavia Montgomery, who led our first breakout session. If you are the reporter, you can go ahead and get started, and our aisle folks will be advancing slides. If you are not the reporter, please introduce your reporter.
Hi, yes, I am our reporter. Can you hear me okay?
Yes, we can.
Okay, perfect. So myself and Carrie Birch with the Mecklenburg County Health Department, we presented at session A, and session A was titled Creating the Foundation for a High Quality Integrated Community Safety Net System in Mecklenburg County. So going to access and beyond is what we sought to do. Carrie unfortunately had a commitment this afternoon and can't join us for the report out, but I will be sharing. We can go ahead to the next slide. All right, so all of our formats were taken into a 3P slide deck. So looking at people, process, and then product or service. And so let me see, where are we gonna land? You can keep going. One more. There we go. All right, so this word cloud, this was just very spur of the moment. We threw into a word cloud what a integrated community safety net system would look like. And these are some of the words that populated, that it provides diversified options, that it is a quality product, right? We shouldn't expect for someone to get a lesser grade of care, regardless of their zip code, their demographic, their race or ethnicity. Everything should be of quality. That people have options, that they have a new lease on life, that there are alternatives to the care they're currently getting, that it's easily understandable, thinking about health literacy and making sure that it's able to be navigated with ease, that it's a seamless system, right? We want a continuity of care from A to Z, from prenatal care all the way to end of life care, that it's something that it's convenient for everyone that's involved. We need something new, right? What's been working isn't quite working anymore, or has it ever? So we need something new, and again, something simple. So this is just a quick word cloud that we created. Next slide, please. When it comes to people, we of course are speaking of those with a community health safety net that are uninsured or underinsured. So by underinsured, meaning that perhaps you have an insurance plan, but your deductible is more than what you can afford. Remember, a lot of families that are in this area are cost burdened, meaning they're spending 30–40% of their income on housing alone. And in Mecklenburg County, we see upwards of 70% of their income or more on housing. We're looking at those that have chronic medical conditions or mental health concerns, and those that are underserved. So when we did our breakout session, all these ideas, these are ideas that were generated by the people that were in the breakout session. So this is what, again, the ideal safety net system looks like. It would involve providers of all kinds. We'd be making sure that the insurance companies or the health plans are engaged in this work, that we're wrapping in our local government, and they're providing consistent support at the city and county level, even statewide, as we start to think about Medicaid transformation. That we're making sure that large employers or corporate entities are engaged in this work. And of course, that we are organizing as a community and ensuring that policies are going to support the different processes that we're creating. Next slide. When we think about the process, not only are we thinking about the process for the consumer, but we're also thinking about the process for the providers as well. So we're wanting to make sure that there's education all around for everyone, with programming and awareness, that people have different tools that they can encompass. We want it to be accessible. So right now in COVID world, we are in this conference via Zoom through technology, and we've seen a lot of advents with telehealth services in the last year or year and a half as well. So we want to make sure that that's accessible. I know that's something that CareRing was able to offer this year through COVID, is telehealth services, and it's been very popular. Providing incentives for everyone, consumer and provider alike as well. And then looking at this from a systemic level. So making sure that Medicaid transformation, it will provide insurance coverage for some people that it had not before, but we still know there'll be people that are going to need to be wrapped into that safety net. Redefining what our insurance system looks like as well. We looked at a program out in San Francisco that is an excellent and outstanding example of a universal coverage system within a city. So we took that a part of it and incorporated that into our ideas as well. And then looking at timeliness of care, people should be able to get care that's easily accessible. They should not have to wait an extended period of time to get that care. So looking at hours of operation that meets the needs of the people that we're serving, making sure that there are staff to do that as well. Next slide. And then our last slide is looking at the product. So what would we be delivering as far as care? Again, it's affordable, it's community-based, right? We can't expect for people to always come to a brick and mortar. Maybe we go out into the community more, or we have telehealth services that are able to serve people in the comfort of their home. Health services, so again, integrated data. Can we all see the same patient through the same lens? Looking at transportation, our community infrastructure is changing. I believe we have a lot more work to do to make sure that people have this accessible, but there are other options like Uber Health or Lyft that we might be able to utilize. And then last but not least, again, the product around timeliness of care, making sure that everything is organized and we're able to address the needs of the people that live in the communities that we're looking to serve. If we know that a lot of folks are working second shift jobs, are there providers that are able to see people after those hours, or do they have early morning scheduling to meet their needs? So I believe that is my last slide.
Thank you, Trinavia, and thank you, Breakout Group A. That's fantastic. We are going to move right on to Breakout Group 2. We've got Dr. Elizabeth Racine and Mamie Saki-Harris led that group. Or which one of you is the reporter for that group?
Can you hear me? This will be Mamie. And I'll actually just use the summary slides I have here. What we sent to you is not quite complete, so I'll just read off what I have here, if that's okay.
Okay. Okay, we'll stay on this slide.
Yep, so Elizabeth Racine is unable to join us, and so I'm going to be reporting out for our group. And we just basically, we had a great discussion. Our section was on food security in the Charlotte region and addressing that, looking at it from the social determinants of health. And we broke that down into the people, the process, and the products. And I'm going to start off with the discussion, brief points we came up with on people. And one thing that we discussed was the importance of having some ways to collaborate. There's a lot of information on food security, so the desire was, how do we hone all that information in one place? So a key thing for the people was, who do we bring to the table so we can have some unified collaboration on food security across the Charlotte region. So that was one thing. And then the other thing that was discussed in this section was also identifying new groups. How do we have new groups coming out to into this food security discussion? There are groups that we felt were not necessarily properly identified. So trying to ensure that we could have some of those individuals at the table in collaborative discussions. And then the other thing that came up was also working with the universities to work together on some of the policy aspects that were coming up, that we saw coming up for the county. There were situations like the SNAP restaurants program. This is something where hot meals can be served. Individuals can use SNAP EBT to purchase hot foods. So this is a program that is done in just a few states, and it's typically for the elderly population. And so an example was, could that be explored? And of course, we know that's a policy level system. And that was that for with regards to people. The third bullet will be struck out. The next we spoke about was on the processes. So for processes, what we decided were key topics were having some sort of county-wide nutrition education. From our discussions, we realized that there is a need for things like, example, SNAP-Ed, and how do we have broad food security and food nutrition discussions, and then also encourage wider and more virtual platforms, so to determine how we could use virtual platforms for food delivery in more efficient ways. An example for the senior population, I had mentioned in the presentation, the grab and go, which is replacing congregate sites. But in a model like that, what we were looking at was, for elderly individuals, how can we partner? How can Meals and Wheels partner with some groups that do virtual platforms, example, Amazon, to roll this out in a more efficient way across the county? And that was an example that was brought up. And then also developing systems to help really provide broad county-wide resourcing and discussion, so bringing more awareness to what was happening in the food security space. There was a need to identify clear strategic systems to encourage information sharing, so individuals can or organizations could easily have in one place what's information on food security for the county. So how do we have processes that would pool information like that together? And then finally, with regard to products, and that kind of touched on the topics that we're bringing. It was more identifying, do we have some sort of a QR code that can be used to identify these food resources? Do we have some online model where people can go and actually access information on food? And then also, how do we put a policy into action if we wanted to do something like broadening the SNAP portfolio? Thank you.
Thank you, Mamie. And group 2. Our third breakout group was focusing on creating a data-driven learning public health organization. The breakout was led by Jonathan Ong and Frank Diaz-Garelli. Who is our leader for that report out?
Good afternoon, Dr. Fortfather. This is Jonathan from Mecklenburg County Health Department Informatics Program. So good afternoon, everybody.
Hi, Jonathan.
Hi. So I'm just going to start off by just giving everybody an overview of the module that we've had, where we spoke about Public Health 3.0 and the response of Mecklenburg County Health Department and the response of University of Charlotte, UNCC with regards to Public Health 3.0. So we were able to come up with this 3 Ps to answer what everybody has given us during the breakout sessions, as we had breakout sessions throughout that particular discussion. So, Dr. Frank, before I begin with this, do you have any words for the group?
No, just looking forward to sharing this. Thank you.
Yeah, thank you very much. So, when we talk about people within this particular scenario, we had identified, and the group had identified things such as providing in-service needs on how access of data and use of data. So a lot of talk about staff training and in-service are needed. The ability to translate high-level data to consumable information. So what we have identified for this particular bullet was that we've done a lot of training in the academia with regards to doing all your regressions and your programming and your Pythons and those kind of things. But at the end of the day, we need to be able to help translate high-level data so that people can make it and use it for decision-making, for staffing plans, and so forth. Access to data literacy, management, and analysis training, and that includes the training for Public Health 3.0. And we did identify that there is a need for not just training of Public Health 3.0 on the leadership level, but also for across the board, including staff. Of course, access to the results from Public Health 2.0. One of the ideas that was thrown out during the conversation was having, let's say, a Twitter feed of how data that staff are collecting actually translates to either an outcome or a funding or that type of output. So they want to be able to see the results, not just about what it is. Next slide, please. When we spoke about process, we did speak about ideas that will help build systems that will automatically share information and to understand the patient's social determinants of health in context. So one of the ideas that was brought out by our colleagues from our dental program in Mecklenburg County was having the data from their clinic be able to feed information to services for nutrition or even for vaccination. So I know that within Mecklenburg County, there's a lot of activities already that involves the health collaborative of bringing data from Health and Human Services into a single view of that particular citizen. And also for Mecklenburg County this year, we're actually working to be able to access the State Health Information Exchange so that not only we have access to data within our EMR, for example, but to be able to have access to data that's being shared by health organizations throughout the state through the State Health Information Exchange. The other things that was also suggested was building of systems that support reporting of issues electronically and automatically. As we know, there's still a lot of manual processes that's involved within public health and in public health in general. So one of the areas of interest will be health integration with dental. such as child abuse and neglect reporting. And of course, one of the things that was shared within our group was a shift of perspective. So not only did we have a shift from a typical IT service that's provided by the county, but now understanding that there's a specific niche to a health IT service that will help drive public health services. So that's one of the discussions and information has been shared with us, given that we have a very wide range of people during our breakout session. Next slide, please. And of course, in terms of the product that came out from this, we want to be able to have data-driven insights based on social determinants of health and make indicator development easier in the field, strengthening the link between public health and clinical practices through data sharing, creation of dashboards to understand patients' place in the distribution, and of course, aligning data-driven initiatives to support existing workflows and match public health 3.0 needs. So I think these 3 bullet slides really summarizes what public health 3.0 is, and actually in terms of my area of expertise of public health informatics, it's really aligning the people, the process, the policies, and of course in the context of data in itself. So I think that's what we have really derived from everybody in terms of their idea of what a data learning environment is. And one thing that to highlight, and I think Dr. Frank can continue with this, is the fact that being data driven does not really mean having all the high technology available to you, but being able to have that way of thinking of how data is being used to drive your process. Dr. Frank?
So the overall impression that I got from the feedback was that the community wanted more of a community feel with more openness in terms of why the data was being collected, what was being done with the data, and the results of how that got us to do more public health 3.0 oriented things. There was a lot of interest in training and potentially creating groups where information could be shared. But overall, it was more about creating community and providing support for that community to be built. That way people get to feed off each other and understand how to leverage the data that they already have into better uses to improve the way the work that they're already doing. Thank you.
Thank you, Jonathan and Frank, and breakout session C. You guys did a great job there. Our 4th breakout was focusing on interprofessional education. The breakout was led by Dr. Shanti Kulkarni and Dr. Kelly Powers, both of whom are faculty at UNC Charlotte, one in social work, one in nursing. Which one of you is leading the report out today?
Hi, this is Kelly Powers. I'm going to lead today. Dr. Kulkarni had another obligation. Can you hear me okay?
Yes, I can. Kelly, take it away.
Okay, great. Thank you. So we focused on addressing social determinants of health through using interprofessional education. It is vital that we increase the team approach to care within our public health care settings. And one of the great ways to do that is to infuse interprofessional education in as a model, because it will encourage team-based approaches from existing staff, as well as prepare our graduates to be team-based in their approach. So a lot of the polls that we did in our breakout session indicated that team-based approach, interprofessional approach to shared decision-making really isn't in place. A lot of consulting with other professions and getting input, but not necessarily a team-based approach with that shared problem solving, that shared decision-making that is so important when we're dealing with complex situations that need multiple perspectives. Can the slide advance? Oh, thank you. Again, sorry. Our slides are a little different in layout. Can you advance again? Okay, so instead of formatting the slide with the people, process, and products, we kind of infuse them all into 3 slides based on priorities. So in each slide, you'll see the people, the process, and the products, but it's based around overarching priorities. Our first priority that our group identified was to raise community awareness about the benefits of IPE as a way to address social determinants and improve population outcomes. It was very clear in our discussions that it's a paradigm shift. It is changing the way it's always been done, which we hear, all the time. This is the way we've always done it, and we really need to infuse education in order to get people to change their perspective, their way of doing it, into this team-based approach. So we discussed having, community-wide lunch and learn sessions. AHEC is doing things like this, performing site education to overcome resistance to change. My dog, I'm sorry. Having champions to educate content experts from multiple professions. That way that there's buy-in from all professions. One of the things Dr. Kulkarni and I have learned from doing IPE is that through doing it together, we offer multiple perspectives for our learners and for the staff that we work with. Having IP content as experts as trainers to provide that lived experience and share insight on overcoming barriers and ideas. And then to really raise awareness by disseminating outcomes of doing this at pilot sites. And we talked about the work we're doing right now in collaboration with colleagues on student hotspotting, where small interprofessional groups work with complex patients to be able to address their medical, mental health, and social needs. And it's resulted in improved patient outcomes that when we've published this work that reduce utilization of the ED, improved utilization of primary care services, and reduce cost. The needs we identified was making sure that there's time and resources and reimbursement for education experts, the ability to provide continuing education and or on-site during work hours education to really promote widespread education. That was our goal. And then, of course, leadership support and buy-in with IPE being identified as a priority for sites. Next slide, please. Priority 2 feeds off of that one, and it's increasing leadership buy-in and support. We talked a lot right now about how healthcare sites they have multiple priorities, and how could we shift IPE to the top of those priorities as a way to inspire change in the current culture of working in silos and as a way to improve outcomes. Strategies that we identified were education about the need and the benefits of IPE, including recruitment of well-qualified and trained individuals, addressing retention and burnout, improving health outcomes, and the financial benefits. Another strategy was making sure that IPE is part of documented and discussed priorities and strategic plans. Making sure there's logistical support. IPE requires a lot of coordination from different people, different groups of learners, different groups of preceptors. So having logistical support would decrease the burden of leaders wanting to participate in IPE. And then exploring successful models. And we really talked about our desire to explore and try to find models of IPE in community-based settings, and to really, IPE started in acute care settings, but it really is needed in community settings where the care is so complex. The needs were to identify sites that have multiple disciplines, have staff that can serve to precept these disciplines, and has a client population that would really benefit from an enhancement of the interprofessional approach. Identify site barriers to IPE, doing needs assessment so that we can overcome those barriers. And then, of course, again, protected in time, reimbursement, resources for experts to be able to recruit sites, prepare them, coordinate. Priority 3, please. Thank you. And our third priority would be to develop pilot sites in diverse community care settings to serve as models, and then use the outcomes to provide evidence as to the importance and success of IPE within these sites. So we really talked about identifying diverse community site opportunities where there are complex needs. One that we talked a lot about is in schools, having interprofessional learners to really pull the team together and focus on the multiple needs of the children and families. And that was just one example. Developing IPE site champions, provide them training, give them support, and make sure they're recognized for their work in helping improve interprofessional collaboration in their site and prepare our next generation of professionals for practice. Implement pilot IPE model sites and evaluate outcomes with dissemination of outcomes to provide the impetus to grow more IPE focused sites. So start small and grow bigger. Needs, again, are leadership buy-in, support, training, and recognition for staff who would like to serve as interprofessional mentors and preceptors, coordination between health professions training programs and community health sites, and funding for researching and outcome evaluation. And those are our 3 big priorities that encapsulate the people, processes, and products. Thank you.
Thank you very much, Kelly, and all of you who participated in breakout session D. Our 5th and final breakout session is the one that focused on housing in the built environment. It was led by Rachel Stark and Hannah Curlin, both of whom are very active in our Charlotte community. Which one of you will be leading the report out today?
Hey, Dr. Forthifer, I will. I'll be reporting out on our group.
Wonderful. Go ahead and take it away.
All right, great. So just a little bit of background about talking about the built environment. So we're talking about the housing and the infrastructure, commercial and urban use of the land. And as you guys know, we're currently getting feedback right now, holding multiple various public forums on the Charlotte Future Plan 2040 and asking people to give us feedback about that. So this comprehensive plan, could it come at a better time right now than, for us to kind of be thinking about these types of things. And I would really encourage everybody here to give your feedback to this plan, because this is the future of Charlotte, and looking at this link between food insecurity, house insecurity, and just Charlotte's incredible growth and development right now would be instrumental. So I highly encourage all of you all to do that. So first, talking about people, our group had suggested that we do these feedback loops, including long-term residents, so people who've been here 20 or more years, about these development projects, and really reaching out to them about moving forward and their ideas, suggestions, that type of thing. And then keeping in mind Charlotte's history and including those into the development to be respectful of the existing and long-term residents, and kind of adding our past history with trade and commerce and the railroad and those types of things, so that when we are adding these things in, we can be respectful, culturally mindful, and really enhance what we're creating moving forward. Okay, next slide, please. So talking about the process, an idea that really went over well was a centralized place to see all properties available for rent or purchase. Unfortunately, a lot of times people have a hard time finding available apartments or homes for rent and have to search multiple websites. So kind of we do coordinated assessment for those that are housing insecure or homeless, something along those lines, where a centralized place where we can have up-to-date, up-to-the-minute, information. Creating a landlord registry for accountability. The city of Charlotte is unique in the fact that we do not have a landlord registry. So any and everyone can be a landlord, and there is no process to do an assessment to check homes or apartments to make sure that they're up to code, that they're safe for residents. And then, as you guys know, unfortunately, sometimes residents or tenants do not feel comfortable asking for repairs or reporting to code or that kind of thing. And so this would be one way to counter that. And then finally, a policy that would kind of address, development and the balance of land. So, if we are building 100 units, then we in return are saving X amount of natural habitat, green space, creating a park, that kind of thing, in conjunction with, taking away that space otherwise. So a policy or a mandate that the city would have so that we could balance out both of those priorities. Next slide, please. And then finally, we're talking about product. We're looking at, a project that we could do quickly. We know we've got, lots of public transportation plans in place, but, looking at people having access to transportation to community health events. An idea earlier was talking about like the Uber Health or whatnot, something along those lines, right? So I think we are talking about similar things. We had talked about people trying to reach large vaccinations, that kind of stuff. So how can we make sure that people have access to transportation and that there's not a financial burden onto those people as well? Provide simple interest loans to allow homeowners to pay off their homes quicker. A lot of times people don't have access to the same type of financial tools. So what is something that the city could implement in the meantime? And then create a financial aid service for people wanting to build ADUs. These are accessory dwelling units, otherwise known as like your mother-in-law or your granny unit. They're usually kind of, in the back or on top of the garage or whatever. A lot of times these units are, they have electricity, they have their own bathroom and whatnot. So how can we, increase the number of ADUs, so allow more people to live in, these types of spaces, because currently those are no longer permissible to build. So creating, financial aid service so that people can apply for loans to build those, so we can increase the number of affordable units here in the city. So, and that's what we came up with. Thank you.
Thank you, Hannah. I'm encouraging folks to use the chat as a way to list any questions or comments they might have. And Natasha, you can switch the screen back to me when you're ready. So I'm going to take a stab at summarizing what I heard today. And this is, as remember, I just want to say at the outset, I said that the one thing I was sure of at the end of this session was that you would all be mad at me. So this is where I dig a hole for myself. I'm going to attempt to take all that excellent work that was done today and summarize what I heard in the most kind of encapsulated form, but I want you all to react to it, because our charge in this session is to come away from this session with sort of some next steps that AFI, the health department, the university can continue to work on in partnership with all of you. So I want to start by just saying that as we think about synthesis, we can easily think of this in terms of consensus, and consensus is a great idea, but it's a hard thing to achieve. We are talking about wanting to have cooperation among a lot of different partners who are functioning as equals, and that doesn't always mean that we're unanimous in our perspectives on things. So we're talking about achieving kind of an agreement to move forward on common themes which may acknowledge that not everyone is of the exact same mind about how to do that, or that there are other priorities that also deserve attention. And so